Well, welcome everybody to another segment of Lewis at Large. Yours truly, Warner Lewis, is always at the controls on the flight deck, and Smart Talk Radio, as always, is in your future, and this segment's certainly no exception. This is a first. We have done over 800 shows in this series. We have never talked about anesthesiology, and we're going to do that. We're going to talk about your anxieties and probably some of those of the physicians and doctors that administer that anesthesia to you. A brand new work called Counting Backwards, A Doctor's Notes on Anesthesia by Henry J. Pryzyblo. I think I've got that right, and we're going to start with that. Henry, how are you, my friend?
Hey, you nailed it, Warner, and thank you very much. And I feel a whole lot more comfortable if you call me Jay.
Okay, Jay it is then. That's good.
I've been Jay since the day I was born.
Okay.
I don't know why my mom named me Henry, but I was Jay from the time I came out.
No, that's fine. That's fine. Jay's easy to remember. Well, let's do this. Share, if you would, with our listeners a little bit about what led you to medical school and what led you into anesthesiology in particular.
Medical school is interesting because my family was so rooted in middle class. There wasn't a physician anywhere near us. As a matter of fact, the closest I came to a physician was when he was coming at me with shots for vaccinations. And that same man actually did the pre-medical school physical for me and wished me a great amount of luck. I don't know. There really was a drive to do something that was meaningful to me, something that was helpful. And I don't know where the fire came from, but that's how it started. Anesthesia, basically $600. It was bought very, very cheaply. In medical school, you have your rotations that you have to do in the mandatory ones, but then you have a number of elective rotations that you can fill in. And I was sure I was going surgery, and so I was looking at what the electives were, and I thought, I'm going to get all the surgery I need after medical school. I thought, anesthesia is an important part of surgery, so I started looking at it, and then I found, lo and behold, there was a $600 stipend if I did the rotation. So I signed up right away. Now, just to let you know, I was married and I had an infant son at the time, and we were living literally at poverty level. And so I promptly went and took that $600 and bought some kick butt speakers and Bruce Springsteen's Born to Run. And I don't know if my wife ever forgave me, but that's how I got into anesthesia.
That is essential. Those are essential tools for a young family. No question about it.
Yes. Well, very much so.
Okay. Let's, I went under the knife a while back and was talking to my anesthesiologist, who, by the way, whose name was Dr. Breath, legit.
Yeah.
Anyway, and of all the things, my guess would be that the layman thinks if you had to pick, sort of speak, a risky one, it would be anesthesiology. Is that a misnomer, or is that true? And if it is, are your palms sweating every time you go into the OR?
I practice self-control to a great extent, so my palms don't sweat very much. But aside from that, today, anesthesia is incredibly, incredibly safe. On the other hand, there is no specialty that dabbles in all the vital signs of every body function as much as anesthesia does. So we can certainly go awry very, very quickly. Fortunately, we have enough monitors and enough safety. We know our medications well enough that rarely happens. And fatalities from anesthesia today are extremely rare. It's like last year, I think there was just a hair over 300 deaths from anesthesia, 40 million anesthetics. So it's incredibly rare. But, it can happen.
Are there particular kinds of surgery? Is a lengthy surgery, for example, let's say a long open heart surgery, something to that effect, versus something like a quick, some orthoscopic thing with somebody's ankle or knee or something, are those preferred by you necessarily? Are they more difficult, or in essence, is the job the same regardless of the time?
It depends on the particular case, and I try and tell people, patients and families, that some of the most critical cases that I can take care of last literally minutes, and those are the cases when there's pressure around the heart or pressure on the brain, and you got to get that pressure off, otherwise things are going to go very bad very, very quickly. Take minutes, high intensity the entire time, and some of the most benign cases just take forever. In my field, I do kids are mostly my specialty, and we do dental rehabs, they're called, when kids have multiple caries and they're not going to sit in a dental chair, but you anesthetize them, and those can take hours, and yet they're very, very benign. So the time does not necessarily mean it's a bad case versus a good case. I just migrated to the difficult cases, and so I take care of a lot of people with heart disease, and they keep you on your toes. And that's okay with me. Sweaty hands, there's times when you certainly the anxiety rises, but it sounds so condescending, but I've tried very, very hard to remain calm under all circumstances. I tell people, there's time to go home, grab a pillow, run into the bathroom, and scream as loud as you can. That's after everything's done.
The baby boomers that had tonsils out and all those other things that they had, probably broken collarbones falling off of Schwinn bicycles, etc., probably have heard the term quite often, ether. Is ether still a part of this mix at all, or is that long, long gone?
It's not at all long gone, but ether has a different connotation for some people. The first anesthetic that was used was called ether. There's something called diethyl ether. It had a couple of carbons and oxygen and a couple more carbons. And we've subsequently perfected that a lot more, but it's still an ether I'm using today, except my ether that I'm using today has 1 carbon, an oxygen, and 3 carbons. So it has very similar skeleton, and it's still an ether by class, but it's a different drug. It has some different side things on it. The drug I use today is called sevoflurane, so it's not diethyl ether, the common name for ether, but it's still an ether in chemical class.
It's probably obvious, but what is as you look around at the surgical team, the doctor, the attending physicians, whatever, the nurses, and whatever support staff besides yourself is in that room, what do they look to you to do? I mean, how do they look at the anesthesiologist? Is that someone on the pecking order that is what you say goes, or are you taking orders? How does that sort of hierarchy work within OR?
Oh, the important points for anesthesia, the ones that are higher intensity with everybody needing to be all hands on deck, so to speak, are the times that the anesthesia is being induced and the time that the patient is emerging. Those are times when a lot of vital signs can change very, very quickly. There's a lot of changing in terms of what the patient's feeling, going to sleep and that. So everybody has to focus completely on the patient and what the anesthesiologist is doing at that particular point in time. The maintenance part is different depending on the case. It's some of the brain surgeries, some of the heart surgeries, and certainly the ones on the liver. You're on your toes the entire time. And the people in the room are paying attention to both the anesthesiologist's needs and the surgeon's needs, for blood transfusions, for products that we have to get, for other drugs that we need. Everybody's on. But in the other cases, it calms down in between. And that's okay with me.
If you just joined us, yours truly, Warner Lewis from the flight deck, of course, as always, Lewis at Large, and in the midst of a good one, talking to Henry J. Pryzyblo, anesthesiologist, brand new work called Counting Backwards, a doctor's notes on anesthesia. It is important that we refer to this guest as Jay. So, Jay, we continue on here. Tell us, to the extent that you know, how did anesthesia as a concept, other than knocking somebody out, the chemical sort of modern version we know today, what is it and how does it work, and how do you get someone into a state of whatever it is, sleep or unconsciousness, but not take it too far?
Okay. First of all, the introduction of anesthesia, it was a term that was developed after the first case was actually done, after the first couple of cases were actually done, and it was meant purely to be without feeling. Anesthesia started with ether, and ether was actually a party drug. It was a fairly common party drug, especially around students in medical school and around medicine at that time and during the early 1800s. And then when it hit about 1840, people were starting to think that this could be a really good thing. They were looking for ways to keep people comfortable while doing painful procedures. And at that time, there were 2 big classes of procedures being done. One was a lot of oral dentistry because of abscesses and pain from tooth infections and broken teeth and that. And dentists were trying to figure a way to take those teeth out, treat those teeth without the patient screaming too much. The other one was fractures. And when a patient had a fracture then, especially when the fracture broke the skin. They were bound to get infected, and that was going to be a deadly issue. And so those patients actually went for amputation. And so they were looking for a way to try and make life easier for the both the dental and the amputation procedures, and that just grew out of that. So then, when painless surgery was founded, then medicine exploded, especially in the 1880s and beyond. It just exploded. Now, how you keep people within a safe realm? Adults usually go to sleep with medicines that are pushed through an IV. And you have a good idea of what the dose is based on weight to have a patient go to sleep safely, and then the gas is turned on to keep the patient asleep. Children's a little bit different. Children, you don't have the ability to put in IVs very frequently. They won't tolerate needles, believe it or not. As soon as you mention a needle, the child is running further and further away from you. And so we have to think of a kinder, gentler way of dealing with that child. So the way that's dealt with them is they get induced by mask. And it takes them 8 to 10 breaths, and they're off to sleep, so it's a little bit slower. In terms of the concentration of the gas, there was a fair amount of work done by a gentleman named Ed Eger, in the 1960s, and what he looked at, what was the percentage of gas that kept the patient asleep and prevented them from moving. And so that's how we decided what the safe area of the gas was, what the safe percentage of the gas was. So that's where that came out. So we know pretty much where the percentage of gas necessary to keep the person asleep and safe. I monitor all of this stuff. Every breath is monitored for the percentage of the gas going in and coming out, and of oxygen and everything else too. So we have these patients very, very well monitored.
So I have a question for you. I've all kinds of again, we refer to baby boomers here, but let's say a baby boomer is getting a hip replacement. Mm-hmm. Are they asleep? Are they unconscious? Is it a line somewhere in between? What is technically, medically, what is their state of being?
Okay. I'm going to break my arm patting myself on the back for this, and I feel a little bit bad about this, but if the person reads the book, they're going to get a complete anesthetic experience. It's a lot about me, it's a lot about my patients, it's all about people, but the reader will get a complete anesthetic experience reading the book. In terms of let's go just a little bit further down the body. Let's say a knee replacement, because it's a little easier to understand. For a knee replacement, I deconstructed anesthesia. So I consider anesthesia to be the all-in-one gas, and then I deconstructed it into its basic components. So for the knee, what you need is to have the patient not have any pain, analgesia. You want the patient to not move. You want the patient to be absolutely stable. Not moving is akinesia. Stable is in breathing, blood pressure, heart rate, and that's areflexia, I refer to it. So they're the 5 A's. The other 2 A's are anxiety relief and amnesia. So I can put a local anesthetic on the nerves just above the knee, and I can make that person very, very comfortable in terms of pain. Now the patient wants to be relaxed, is too anxious, I can give them a drug that's going to sedate them a bit. If they want to have no memory, I have another drug that will eliminate memory. And so with the 3 A's, I can take care of that patient for that knee replacement, or I can have the 5 all-in-one gas anesthetic, and that patient won't have anything, won't know anything around. Consciousness isn't even defined. So that's what's awake, what's asleep. What I can tell you is that you hit a certain part on the anesthetic level, and you are completely amnestic. So even if you're moving, there's still no consciousness there. So the deep anesthesia is definitely unconscious, but I can lighten that with various drugs and get a little lighter, and the patient's still able to answer questions but comfortable.
Right. I just know that the times that I've actually been put under, it's a matter of, okay, here I am with the doctors. If I blink my eyes enough, one of those blinks, I'll wake up and it's over. I mean, with no memory. I mean, literally no memory, literally the blink of an eye. And so there's that freezing of time, so to speak, and that is certainly a much different state than just pure deep sleep.
It's very, very different. I mean, and here's where life gets very, very interesting in terms of consciousness. You can be asleep during the night and have very, very vivid dreams. You can be awake during the day and daydream and not remember anything for, let's say you're driving in the last mile, you suddenly say, what happened? Where did that go? And that's where the definition of consciousness gets very, very hairy. But under anesthesia, if I'm giving you, the full Monty, the 5-in-1 gas, you're going to be totally unconscious. And I mentioned, I steal time. I induce a chemical coma, I steal time, I prevent memories. And that's exactly what the drugs do. The gas does it all. I can do it with a combination of intravenous drugs.
Again, the work is counting backwards. A doctor's notes on anesthesia. Henry J. Pryzyblo, we call him Jay around here. Jay, what about, this begs the question, of course, again, like the cobbler's children's, have you been put under, and what was it like for you, and how were you a good patient?
Yes. Yeah, I had a turkey bowl accident. It was a Thanksgiving morning football game, and I managed to fracture the upper arm, and it needed to have surgery to make it functional again. And here's one of the person who I tangled with just added that I wanted to be a superhero, and so I had the fracture, and I had to have anesthesia for it. And the actual anesthesiologist was somebody I trained, showing my age a little bit. And I thought I did very, very well through the procedure in that. In the evening, I asked for some pain medication, and they came in with, you can have a pill. And the nurse was very sweet, and I tried to be very nice. And I said, I'm sorry. I could get stronger medication at home. I'm not taking a pill.
Yep.
She says, okay, doctor, let me see. And the next thing I know, there is a resident of orthopedic surgery, didn't even come in the room, just opens up the door and says, okay, doctor, what do you want me to order? And I told him what to order, and it was ordered. And the next day, my friend, who was the surgeon, let me know that I possibly was a little rough on them. I didn't think so.
Might have crossed the line a little bit, huh? That's,
I may have, but I didn't think so.
Okay, let's do a little prognostication here, Jay.
Sure.
You've been around in this business for a while. What's the next, so to speak, go out a few years? What's the next big advancement in this world of putting people to sleep for surgery?
Well, I think surgery is evolving, and anesthesia will evolve to keep with surgery. One of the things is that we're moving away from surgery and more into procedure-type things. We're starting to go with a lot less invasive procedures, and as a result of that, we can lessen the anesthetic or actually be more precise with the anesthetic that we're giving. So what I see coming up is I'm going to be doing a lot more of picking and choosing drugs to accomplish an endpoint that doesn't necessarily use the gas that much, so that you don't have the total, I'm totally asleep type thing. As I said, we're going to get very, very good at putting medications on nerves to take specific areas of the body and make them pain-free. And the knife is getting less and less every day, so the pain may be a little bit differently. The other thing, and this is what I urge for all people, is that not enough people ask the anesthesiologist, hey, how are you going to make me comfortable when I emerge? Historically, the role of the anesthesiologist was only within the procedure room, and as soon as the patient was awake in the recovery room, it was somebody else's to take care of. And no, that doesn't work for me. Make sure that pain plan extends into the recovery and beyond. So I think some of the things that we're doing will do that, and I hope people ask for that. I hope they ask their anesthesiologist, what are you doing for me after I awake?
Well, you teach at Northwestern University Medical School at the center.
Yes.
You're now an author, anesthesiologist. Pick one of the three. If you had to do one thing for the rest of your life, what would it be?
Oh, Warner, that's an easy one for me. I am absolutely the happiest when I have a child in my arms that I can care for. I mean, that makes me the absolute happiest. But, it's coming to the end. I've 30 years, 30,000 cases. I've seen everything. I've done everything. The only thing that I haven't cared for are people with lung transplants. But everything else I've done. And writing was a nice challenge for me. And now I'm going to give you a little bit of a sob story because I went into writing for my wife. My wife had a brain aneurysm that left her brain injured, not physically but mentally. And so I went into writing as kind of a therapy for me, and I was writing about our life and trying to rationalize everything that happened. But the second thought was to be able to do something that I could be with her and still be productive. So I just wouldn't be sitting around, watching her, following her, making her feel bad. So I could be productive. There's that saying that fools plan and God laughs, and I did become a writer, but my wife also passed away. So, what can I say? It's writing has given me a place of peace right now. So I'm proud of Counting Backwards. I think it's a well-written book. Again, I'm patting myself on the back. But I also think the people who read it are going to get multiple things out of it, including what an anesthetic is. So that's where I'm at.
Well, we are very, very pleased to have had you here. Again, this is our first show ever dedicated to the science of and the study of and the subject of anesthesiology and anesthesia. Anyone that has been under the knife is keenly aware of who their anesthesiologist is. Again, the work is called Counting Backwards, A Doctor's Notes on Anesthesia. Jay, how can people pick up a copy of the book and maybe find out a little bit more about you?
Well, this is something that's new to me. Going out and pounding for myself. Usually, I just let my work, my care, show it. HenryJMD.com, spelled out HenryJaymD.com. I had very professional people build a beautiful website, and people will get a lot of information, excerpts of the book where the various places I've been appearing in, interviews I've been doing. It also gives you the links to the book, and they're on Amazon and Books A Million and Barnes and Noble. And I got to tell you, I got giddy. If you got a half a moment, I got giddy this morning when somebody sent me a picture from the airport, and there is my book in the bookstore at the airport. And I thought, oh my Lord, I reached it. So
you are big time.
Are hearing it too.
You are big time. If you're racing to a plane, you look over and that blue book is sitting out staring at you right on a rack. That's there you go.
Ultimate gratification.
Yeah, what you don't want is 2 years from now is a big 50% off sticker on it.
That's what I was saying, is that I'm hoping it's not on the discount counter at the bookstore.
Well, listen, thank you so much, Jay, for sharing a little bit about not only the science and the important work that you do, but giving us a little behind-the-scenes look of what anesthesia is all about. And best of luck to you, my friend.
Warner, it's a great pleasure, and I'm very gratified for you asking me to be on your show.
You bet. We'll be back with more right after this.